Hi, my name is Beth DeYoung. I'm an assistant professor of pharmacy practice, and today I'll be talking to you about the medications that we use to manage schizophrenia. I also work with these medications quite often as I practice at the Milwaukee VA, where I run a metabolic syndrome monitoring clinic for patients taking second-generation antipsychotics. And we will definitely be spending some time today talking about the metabolic side effects associated with these medications. These learning objectives do not cover everything that is necessarily important or everything that you'll need to know in practice, but they do cover what I would like you to know for the exam. I would like you to be able to describe the significant differences between first and second generation antipsychotics based on their mechanisms, recommend strategies for managing the extrapyramidal symptoms associated with antipsychotics based on a patient's presenting symptoms, develop a monitoring plan for metabolic effects associated with the second generation antipsychotics according to an ADA-APA consensus statement. You should also be able to recall basic monitoring parameters associated with clozapine to determine the most appropriate monitoring regimen, explain the significant differences among second generation antipsychotics, and evaluate a patient's characteristics to design a treatment plan for a patient with schizophrenia. In terms of goals of therapy, it's important to set realistic goals for patients. Some patients are never going to return to what we consider completely normal, so it's important to know what each patient's baseline symptoms are and what is realistic for them with medication therapy. We also want to set realistic time courses for response. Some of these agents take a while to work, and we want to make sure we give the medication long enough to take effect. We're also going to want to avoid side effects and use the minimum effective dose to help minimize side effects. Patients with schizophrenia often have a very difficult time adhering with medications as well as non-pharmacologic treatments, so we want to try to improve adherence as much as possible. Again, treat for an adequate duration, prevent relapse, and then limit augmentation strategies to non-responsive patients. We'll talk about that sometimes you'll see patients on multiple antipsychotics, and there's really not strong evidence for doing this, so we really want to limit that to patients who truly need it. Just want to mention a few non-pharmacologic treatment strategies. Again, our focus today will be on the pharmacotherapy, but we don't want to forget about the non-pharmacologic options as well. One option is psychosocial rehabilitation programs, and these can really vary, anything from case management to psychoeducation, working on basic living skills, social skill training, work programs, supported housing, financial support. So these are very broad type programs. There's also active community treatment programs, and these are available on a 24-hour basis where providers will come in and work in the patient's home and place of employment to provide comprehensive treatment. This could be things like medication management, crisis intervention, and working on daily living skills. There's also just specific social skill therapies, again, compliance therapy to help them become more compliant with medications as well as non-pharmacologic treatments. We talked about cognitive behavioral therapy a little bit in the depression lecture, and then employment rehabilitation therapy where patients can work on employment skills so they can maintain employment. In terms of pharmacologic therapy, we are going to focus on the first generation antipsychotics and second generation antipsychotics, and providers will use different names for these. First generation antipsychotics are also referred to as traditional or conventional antipsychotics. You'll also hear people call them typical antipsychotics or neuroleptics. Neuroleptics, the definition really is just to produce slowness or absence of motor movements as well as behavioral indifference. And then second generation antipsychotics are often referred to as atypical antipsychotics, but if you're going to use the most proper terminology, they should be referred to as first or second generation antipsychotics. Listed here are the first generation antipsychotics that are available on the market. Chlorpromazine was the first antipsychotic on the market, and all of these medications are available generically. They've been out for quite a long time, and we don't really use these medications as often anymore because of the second generation antipsychotics, and we'll talk about why. Of the first generation antipsychotics, people are most familiar with haloperidol, so that's the one you may see most often. As primary care nurse practitioners, you probably will not be prescribing these medications, but you'll definitely see patients on them, and it's important to be able to help manage the side effects that come along with these medications. You should have already learned that patients with schizophrenia are thought to have an excess of dopamine. So these medications work by blocking dopamine, and they specifically have a high affinity for the dopamine 2 receptors, and so they will bind to those receptors and block dopamine from binding. This is thought to reduce some of the positive symptoms of psychosis and is also responsible for some side effects that we'll talk about. Typically, at least 65% occupation of those D2 receptors is necessary to decrease positive symptoms, but blockade of about 80% is associated with extrapyramidal symptoms or movement disorders. With the first generation antipsychotics, about 70 to 90% of D2 receptors are usually occupied. So you can see that we are going to end up with some of those movement disorder side effects. We also get blockade of muscarinic, histamine, and alpha-1 receptors. So with blockade of muscarinic receptors, we will get some anticholinergic side effects. With histamine blockade, we'll see weight gain and sedation. And with alpha-1 blockade, we will get orthostatic hypotension. This slide lists the dosing, which I do not expect you to have memorized for the exam. It's just there kind of more for your information. The manufacturer's maximum dose is listed. Oftentimes you will see providers exceeding these doses, and that's not uncommon, but it should be done with caution. The first generation agents are listed with chlorpromazine dosing equivalents, and this allows you to dose adjust when switching from one agent to another, so that's kind of a nice aspect of the first generation antipsychotics. I also have the potency listed. The potency indicates the potency for the dopamine 2 receptor, which has implications for side effects. Extrapyramidal symptoms tend to be worse with the high potency agents, while anticholinergic side effects, orthostatic hypotension, and sedation tend to be worse with low potency agents. All of these agents are considered equally effective when given in equipotent doses, so there's not one agent that's considered more effective than any other. I also have the dosage forms listed just so you know the various forms that are available for each agent. I want to specifically highlight haloperidol and flufenazine, which are available in a long-acting injectable form. We don't have enough time today to really get into the long-acting injectables, but these are nice. Depending on the agent, it's given every 2 to 4 weeks intramuscularly, and it helps with adherence because the patient doesn't have to take an oral medication every day. They can just come to a clinic for their injection, and then you can kind of track adherence. There are many adverse effects associated with first-generation antipsychotics. This list contains many of the big ones that I think about, but it's definitely not all-inclusive. We will talk about some of these as we highlight various agents throughout the presentation, but what I want to highlight is that things like extrapyramidal symptoms and neuroleptic malignant syndrome tend to be much worse with the first-generation antipsychotics than second-generation antipsychotics, which is one of the reasons we've kind of moved away from using these agents. I also have hyperprolactinemia listed there. Dopamine is a major prolactin inhibiting factor. So with hyperprolactinemia, this can lead to gynecomastia, galactorrhea, menstrual irregularities, decreased libido, and sexual dysfunction, which, as you can imagine, patients do not enjoy. And this is also worse with first-generation antipsychotics compared to second-generation. We can also get cardiac side effects, things like QTc prolongation. Of the first-generation antipsychotics, thioridazine is the most problematic. We also see some dermatologic side effects with the first-generation antipsychotics. With chlorpromazine, you can get a blue-gray or purplish skin coloration. You can also get opaque deposits in the cornea. Certain medications, pretty much all of them, can exacerbate narrow angle or angle closure glaucoma due to their anticholinergic side effects. Of the first-generation antipsychotics, chlorpromazine tends to be most problematic for agranulocytosis. We'll talk about a second-generation antipsychotic called clozapine a little bit later that is also problematic for agranulocytosis. And then in terms of seizures, chlorpromazine also tends to be most problematic. Thiridazine, haloperidol, trifluoperazine, and fluphenazine are usually associated with the lowest potential. Seizures tend to be most closely associated with higher doses, rapid dose increases, and on initiation of treatment. So you don't have to have all of those specifics memorized. We will go into some of the things more in depth, and those are the things I'd like you to focus on for the exam. We are going to spend some time talking about the extrapyramidal symptoms, and we can have extrapyramidal symptoms with both first generation and second generation agents, but it tends to be much more problematic with first generation antipsychotics, and that's why I'm going to talk about it in conjunction with these agents. And it's one of the main reasons we've used away from using these agents instead of second generation. The first movement disorder I want to talk about is dystonia. Dystonia is defined as a state of abnormal muscle tonicity, and often patients will end up with sustained muscle contractions, and these can be pretty painful for patients. There are several different forms that I've listed there. I'll kind of go through each one. Torticollis is where the neck twists, in which the head is tipped to one side and the chin to the other. With laryngospasm, you can get spasming in the larynx. With oculogyric crisis, the eyeballs are usually locked in a fixed position, and that's usually in an upward position. With retrocollis, the head is drawn backwards. Trismus is when patients are unable to completely open their mouth, while glossospasm is a spasmodic contraction of the tongue. Then with blepharospasm, this is an abnormal contraction of the eyelid, typically in which the eyelid is forced shut. And then with opisthotonus, this is arching of the back with the head thrown backward. And I do have some pictures of some of these on the next slide to kind of differentiate them. In terms of treatment, we tend to use anticholinergic medications as the treatment of choice. Of the agents I have listed there, benztropine has the longest duration of action, which allows for usually twice daily dosing. So it's often used more than trihexyphenidyl or diphenhydramine, which are sometimes divided in 3 or 4 doses per day. You can also try discontinuing the antipsychotic, reducing the dose, or switching to a second generation antipsychotic. Those are all treatment options that are great options instead of having to add on something like an anticholinergic medication. You can also try using benzodiazepines. That's usually, I would say, second line to using anticholinergics. Oftentimes with schizophrenia, these patients will also have substance use disorders, so you have to be pretty careful with using things like benzodiazepines. So here are some of those pictures of the dystonias that I talked about. You can see with torticollis, that's where the head's kind of tipped sideways with the chin and the top of the head in opposite directions. Retrocollis, you can see the head is drawn backwards. And then with opisthotonus, you can see that arching of the back and head thrown backwards. So you can see these look fairly uncomfortable, and you can see why patients would not have to want to deal with this type of side effect. The next movement disorder we're going to talk about is pseudoparkinsonism, and this really just resembles Parkinson's disease. So if you're familiar with Parkinson's, it looks very similar. And with Parkinson's disease, it's caused by an insufficiency of dopamine. So patients don't have enough dopamine. So it makes sense if these medications are blocking dopamine, we're going to get symptoms very similar to Parkinson's disease. So with akinesia, this is just an absence or impairment in voluntary movement, while bradykinesia is a slowness of movement. You'll also see that resting tremor and then cogwheel rigidity. The picture is kind of showing testing for cogwheel rigidity. Typically they'll test in the elbow joint, and instead of a fluid, easy motion, you'll kind of get a ratcheting or clicking of the elbow where the patient can't make that fluid movement. You also see the same types of things with masked face, shuffling gait, and stoop posture. In terms of treatment, once again, you can always try switching to a second generation antipsychotic, lowering the dose, or just potentially seeing if you're able to discontinue the antipsychotic. Anticholinergic agents are once again used to treat pseudoparkinsonism, as well as dopamine agonists, and the one that is typically used is amantadine. Amantadine is generally as efficacious as anticholinergics with less effect on memory impairment. However, long-term treatment with Parkinson's medications is controversial. As you can imagine, they have the potential to worsen psychosis because they're actually increasing dopamine. So you should make an attempt to taper and discontinue amantadine about 6 weeks to 3 months after symptom resolution. Risk of pseudoparkinsonism is pretty low with second-generation antipsychotics. The agent that probably has the highest risk is risperidone, and we'll talk about that a little bit later. If risperidone is dosed too high, it has the same potential to cause these movement disorders. Next is akathisia, and akathisia is an inability to sit still or motor restlessness. You'll often see these patients pacing the hallways. If they're in an inpatient unit, you'll see them pacing back and forth, or in like a clinical type setting, they're often shifting around in their chair, tapping their feet, kind of, wiggling around and not able to sit still. Of the second generation antipsychotics, aripiprazole and ziprasidone tend to cause akathisia when they're started. Risperidone is also associated with akathisia. And then clozapine and quetiapine are least associated. So again, we'll talk about those agents a little bit more later, but just want to highlight them now as well. In terms of treatment, anticholinergic medications don't tend to work as well for akathisia. So the treatment of choice here really tends to be propranolol, which is a beta blocker. And the one thing to caution you on is that propranolol is a lipophilic beta blocker, meaning that it can cross easily into the brain, and it can worsen depression. So you just have to be careful with that. Benzodiazepines, again, are an option, but they're usually second line behind propranolol due to that concern for things like substance use disorders. The final movement disorder we're going to talk about is tardive dyskinesia. And of the movement disorders, this is the most severe form and something we really want to try to avoid in patients. Tardive dyskinesia is characterized by abnormal involuntary movements, and it's thought to occur due to the long-term blockade of dopamine 2 receptors. And I kind of have this highlighted in the picture that's shown on the slide, and that with this long-term blockade of dopamine 2 receptors, you can actually get upregulation of receptors. So you can imagine if the few receptors we have are blocked, the body will actually produce more receptors. And then once you get this increased amount of receptors, this can lead to hyperkinetic movements. And this is because the receptors are trying to overcome that drug-induced blockade. So with tardive dyskinesia, we'll see a lot of oral facial movements. We'll see tongue thrusting, tongue rolling, lateral jaw movements in which it looks like the patient's kind of chewing from side to side. You'll also see lip smacking, frequent blinking, and brow arching. You can also see movements in the extremities. Choreiform movements are movements we typically see with Huntington's disease. They're variable, purposeless, involuntary, and quick. They can also be kind of rapid, jerky, and non-repetitive. With athetoid movements, these are continuous, arrhythmic, wave-like movements in the distal part of the limbs. Ballistic movements are rhythmic side-to-side swaying. And then axial movements are to and fro clonic movements of the spine in the anterior-posterior position. In terms of risk factors, those who are older tend to be at higher risk. The prevalence is about 5 to 10% in patients older than 40, but as high as 50 to 80% in the elderly. So big risk for our elderly patient population. Duration of antipsychotic exposure is also a risk factor. The incidence is about 5% per year, but can range up to 20 to 25% with long-term treatment. Higher antipsychotic doses, those who have had an organic mental disorder, if they have an occurrence of acute EPS, so things like if they experience dystonia or akathisia, they're more likely to develop tardive dyskinesia. We'll also see increased risks with things like female gender. In terms of preventing tardive dyskinesia, we really want to limit unnecessary exposure. So if they don't need the antipsychotic, also if they're on 2 antipsychotics, hopefully getting rid of one of them to help decrease that risk, using the minimum effective dose, and then using second generation antipsychotics, which have a lower risk. Anticholinergic medications actually worsen tardive dyskinesia. So we really want to discontinue any medication that's anticholinergic. And then we can also assess for signs using rating scales like the Ames and Discus. Typically, the psychiatrists are the ones that do this. It requires quite a bit of training to kind of figure out how to assign the scores, but I just want to make you aware that those are available. Unfortunately, tardive dyskinesia may be irreversible even after stopping the antipsychotic, and that's one of the reasons we take this so seriously. We also do not have any FDA-approved medications to treat tardive dyskinesia. The first recommendation is to taper or discontinue the antipsychotic if appropriate, but just recognize that patients can actually go through a withdrawal dyskinesia when you discontinue that antipsychotic. So that dyskinesia may actually increase in severity for several weeks after discontinuing the antipsychotic, followed by slow improvement over months or years. So the American Psychiatric Association recommends antipsychotic withdrawal only in patients who can tolerate it. We can switch antipsychotics to a more or less potent agent. More potent antipsychotics like haloperidol can suppress tardive dyskinesia in patients with severe symptoms, but this is actually considered by many to be inappropriate because of the long-term impact on tardive dyskinesia, and the safety is unknown. Switching to a second-generation antipsychotic has been associated with reduced tardive dyskinesia symptoms, especially things like quetiapine and clozapine. Clozapine is actually the least likely to cause tardive dyskinesia and can decrease abnormal involuntary movements. However, this data is conflicting. Once again, make sure to discontinue all anticholinergic medications, and then you can consider a trial of an antidyskinetic medication. This slide includes tables of medications that either should be considered, might be considered, or should not be considered for treatment of tardive dyskinesia. And this comes from the American Academy of Neurology and is based on kind of the evidence levels for these treatments. Of the medications listed, I've seen tetrabenazine used most often, and this is actually a treatment for Huntington's disease, so it does not have an indication for tardive dyskinesia, but providers will use it. However, you have to be careful because the adverse effects include things like depression and suicidality, so you have to make sure that that's not an issue in that patient. Vitamin E is listed in insufficient evidence to support or refute use, but I also see providers using that quite often just because the side effect profile is pretty benign, so providers will often give it a shot, although I haven't seen it be too effective for patients. The agents that have most evidence appear to be clonazepam and ginkgo biloba. However, clinically speaking, I do not see those agents used too often. We spent quite a bit of time talking about the movement disorders associated with first-generation antipsychotics. And again, I don't think you'll really ever be prescribing these medications or being the sole person that is responsible for determining how to manage those side effects. But I do think it's important as a primary care practitioner that you're able to recognize the side effects associated with these medications and work as part of a comprehensive team to help determine the best management strategies for these patients. And there are several limitations to them, and one of the reasons we don't use them as often, and that's because they also lack efficacy for the negative symptoms. So while they work pretty well for positive symptoms, we don't see as great a response for negative symptoms. They're not effective for all patients. They have several serious adverse effects. The movement disorders are just one of them. Neuroleptic malignant syndrome is something that's also could be deadly for patients, and we see that more often with first-generation antipsychotics. And then because of all the movement disorders, patients tend to be non-adherent with these medications. No one wants to take a medication that kind of makes them stand out, and definitely the movement disorders are noticeable and help others realize there's something wrong with that person. We're now going to move on and talk about the second-generation antipsychotics. I've mentioned these agents are also referred to as atypical, and the characteristics that define an atypical antipsychotic are not all agreed on. However, I put up several of the characteristics that people will use to define an atypical antipsychotic. One is that it needs to have efficacy for both positive and negative symptoms. Second, it should have low incidence of extrapyramidal symptoms with ideally no EPS. They should also block serotonin receptors, and there should be improvement in cognitive functioning, no change in serum prolactin, and they should be effective for treatment-resistant patients. So of our second-generation antipsychotics, only clozapine meets all of these criteria. We do have several second-generation antipsychotics available, and as you can see, several of them are available in brand name only, so they tend to be more expensive, and that's because those are our newer agents to the market. Acenapine, iloperidone, and lurasidone are the newest agents, so these are some that providers are just becoming a little bit more comfortable with. These agents, like the first-generation antipsychotics, also block dopamine 2 receptors. However, they have varying affinity for that dopamine 2 receptor, meaning that they don't block usually as many of the receptors, and there's also more rapid dissociation from those dopamine 2 receptors. So the first generation tend to bind and really just kind of sit there, where several of the second generation antipsychotics will kind of bounce on and off of that receptor. These agents also will block some of the serotonin 2A receptors, so we'll see more action on those serotonin receptors. Serotonin does regulate dopamine release, so by blocking the serotonin 2A receptor, this actually enhances dopaminergic transmission. So it's good in that we won't see as many of those movement disorders because we're not having such an effect on dopamine. We also have less blockade of muscarinic, histamine, and alpha-1 receptors, so they're not as messy of drugs, so we shouldn't have so many side effects. This slide highlights the various mechanism of action of the various agents, and this is not something for you to memorize, but I just want to highlight that these agents, although they are in the same class, they do have varying affinities for the different receptors. We have dopamine 2 listed there, serotonin 2A, alpha-1, muscarinic, and histamine receptors. And so as we talk about the individual agents, keeping this in mind helps kind of understand and determine what side effect profile you might see with each agent. These medications are metabolized by CYP enzymes, so they are involved with CYP drug interactions. The first generation antipsychotics are as well. Just didn't highlight that because I'd like to spend a little more time on the second generation antipsychotics. The half-life of clozapine is generally around 12 to 20 hours, but you can see there's a large range listed there. And the bioavailability is usually around 70%, even though the range is once again quite large, ranging from 12 to 81%. The bioavailability of ziprasidone is reduced if given on an empty stomach, and absorption is actually best if given with a fatty food. So you'll often see that ziprasidone should be taken with fatty foods. The bioavailability of acenapine is less than 2% if given orally. So this is approved in a sublingual dosage form, and it's actually the only one that has a sublingual dosage form. In a little bit, you'll see some of them are available in orally disintegrating tablets, so they dissolve in the mouth, but you actually have to swallow that. If the patient spit their saliva out, none of it would be absorbed because it's not a true sublingual dosage form. And then acenapine also has nonlinear kinetics, meaning that doubling the dose results in a nonlinear increase in maximum concentration. And then lurasidone also has improved bioavailability if given with food. However, it does not have to be fatty. Here are the dosing ranges for the second generation antipsychotics. And again, this is not for you to memorize. One thing I want to point out is that risperidone, we typically only dose it up to 6 milligrams per day. Although the manufacturer says you can dose it up to 16 milligrams per day, this really increases the risk for extrapyramidal symptoms. So that is why we do not see doses really exceeding 6 milligrams. Quetiapine is often dosed above the manufacturer's maximum recommended dose. I've often seen doses up to 1,200 milligrams per day. And then also want to highlight that several of these agents are available in long-acting injectable formulations. We have risperidone, olanzapine, aripiprazole, and paliperidone that are available in long-acting dosage forms. This adverse effects slide looks very similar to what you saw for the first generation antipsychotics. Basically, any of the adverse effects that you'll see with the first generation antipsychotics, you'll also see with the second generation antipsychotics, but to a lesser degree. So we definitely have less incidence of extrapyramidal symptoms, things like neuroleptic malignant syndrome and hyperprolactinemia. However, the side effects that I have listed in bold are things that you'll see more often with second generation antipsychotics. and that tends to be our metabolic side effects like diabetes, lipid abnormalities, and weight gain. We'll also see more nausea and vomiting due to the effect on serotonin with these agents. This typically gets better after a week or two, but it's important to kind of help patients through that time period and counsel them and let them know that it should get better so that they're able to stay on the therapy long term. The second generation antipsychotics differ in terms of how much they affect the metabolic profile. This table is from the American Diabetes Association and American Psychiatric Association consensus statement that I talked about in the learning objectives. And as you can see, this came out in 2004 and hasn't been updated since then. At that time, aripiprazole and ziprasidone were pretty new to the market, so there wasn't a lot of long-term data with these agents. But since that time, we do know that these agents tend to be the best in terms of the metabolic profile, meaning that they're least likely to cause things like weight gain or diabetes. Clozapine and olanzapine are our biggest culprits. You can see pretty significant weight gain, increases in blood sugar and lipids with these agents, where risperidone and quetiapine fall in the middle. This is just another way of looking at that data for those of you who are a little more visual. Again, you can see clozapine and olanzapine tend to be the highest risk agents for metabolic syndrome. I did include the newer agents, so lurasidone and asenapine appear to fall in that lower risk group with aripiprazole and ziprasidone. Iloperidone probably falls somewhere between the moderate and low group, so it tends to be more problematic than things like asenapine and lurasidone, but definitely not as bad as clozapine and olanzapine. Quetiapine, risperidone, and paliperidone also fall in that moderate risk group. This table also comes from that ADA-APA consensus statement and highlights how often you should be monitoring for these metabolic effects. And you can see that you should get a weight, waist circumference, blood pressure, fasting plasma glucose, and fasted lipping panel before you even start the second generation antipsychotic. After initiating the agent, the weight should be checked at 4, 8, and 12 weeks, and then every 3 months thereafter. Blood pressure, fasting plasma glucose, and lipids should be checked 12 weeks after starting the antipsychotic. And then the frequency is kind of dependent. Usually you'll do it based on the clinical status of the patient. You can see for lipid profiles, they just recommend getting it every 5 years after that 12-week period. Clinically speaking, we will check lipids much more frequently than that. But what I really want you to pay attention to is that after that initial 4, 8, and 12 weeks of monitoring weight, you need to keep checking that every 3 months, and that blood pressure, plasma glucose, and lipid profiles should be checked at least 12 weeks after starting the antipsychotic. Oftentimes I find that psychiatrists start the antipsychotics and then assume primary care does this type of monitoring, whereas primary care sees that the psychiatrist started the antipsychotic and assumes the psychiatrist is doing the monitoring. And often these patients fall between the cracks. And this can be pretty problematic because I've seen patients gain as much as 30 pounds in just a couple of months after starting these medications. And so you really can run into a large problem if you're not monitoring often enough. And as primary care providers, this is something that you can help keep an eye on and help make sure that patients are being appropriately monitored. And this is actually part of my role at the Milwaukee VA as well, is making sure that this appropriate monitoring is taking place. You should consider an intervention for weight gain if a patient gains greater than or equal to 5% of their initial body weight. The FDA actually considers greater than 7% increase in body weight significant, so somewhere between that 5 and 7% range. Diet and exercise is obviously ideal. Oftentimes I'll find patients have pretty problematic diets or aren't exercising, but oftentimes this is hard for patients to make these types of changes. You can also switch to a second generation antipsychotic with low metabolic liability. Unfortunately, I often find that psychiatrists aren't able to switch the patient to one of these agents because they've either tried it and failed it, or they've been stable for a long time on their current antipsychotic and they're not really willing to risk compromising their mental health. So that leaves us to medically treat the metabolic side effects. And this isn't always ideal because it does not address the secondary causes of the metabolic abnormalities. It imposes new interventions and contributes to polypharmacy. You can consider things like appetite suppressants or weight loss drugs. There's a few new weight loss drugs on the market, but I often find that the side effects associated with these agents often outweigh the benefits in this patient population. You can also try something called metformin. Metformin is often used for diabetes and blocks glucose production and improves insulin sensitivity. Although studies are conflicting, metformin may lead to attenuation or reversal of antipsychotic-induced weight gain, and it appears most effective when combined with lifestyle changes. So this is something I will prescribe in my clinic for patients that have this antipsychotic-induced weight gain. Often these patients have prediabetes and are obese as well, so that's just another good reason to maybe start metformin. Topiramate is something that we'll use for mood stabilization and mental health, and this can result in modest decreases in weight and BMI, usually less than 2%. However, it does have cognitive side effects in which it can kind of cause a cognitive dulling or slowing. So for that reason, I often won't recommend this agent. I really only think it's beneficial if the patient can also benefit from the mood stabilization effects of the topiramate. We're now going to review each of the second generation antipsychotics a little more in depth, and I'll spend the most amount of time on clozapine. Clozapine was the first second generation antipsychotic that was developed, and it's our only true atypical antipsychotic. However, we do not use it first line due to side effects, which is unfortunate because clozapine has shown superiority over other antipsychotics for the management of treatment-resistant schizophrenia. So it really is our most effective agent, but the side effects limit its use. So clinically speaking, we really only use it for treatment resistance, which is defined as failing trials of 2 different antipsychotics at an adequate dose and duration, or if a patient has severe side effects with other agents, such as tardive dyskinesia or dose-limiting extrapyramidal symptoms. That in those cases, you'll often see providers go toward clozapine. Clozapine has several interesting adverse effects. This slide does not include all of clozapine's adverse effects, but some that I particularly want to highlight. You'll see that it has several black box warnings, and the one that I'll talk about a little more in depth is agranulocytosis. But it also has black box warnings for myocarditis and cardiomyopathy, as well as seizures. Clozapine is actually anticholinergic, but causes excessive drooling. I have sialorrhea listed on the slide, and that means excessive drooling. This is not clearly understood why this occurs, but you can try to manage it with anticholinergic medications like benztropine, atropine, or a scopolamine patch. You can also get mild to high-grade fevers with clozapine therapy. The fever usually occurs within 10 to 15 days after treatment initiation, and most of the time is just a benign fever. However, you have to be very careful because you can also see fevers with things like agranulocytosis and neuroleptic malignant syndrome, and those things can be fatal. So you really need to do a full workup and rule out the other causes of fever. Gastrointestinal hypomotility can also be an issue with clozapine. If a patient is complaining at all of constipation or abdominal pain while they're on clozapine, you'll want to make sure to get them on an appropriate bowel regimen because patients actually have needed surgery due to severe bowel impaction, and there has been deaths associated with this. The mortality rate for this is actually higher than agranulocytosis, which is probably the side effect that people worry about most with clozapine. So I just want to highlight that people often forget about this or miss this, but it's important not to put too many other anticholinergic medications on board with clozapine so that you don't get that constipation. I want to spend a little time talking about agranulocytosis because there's very specific monitoring that must occur with clozapine, and patients actually go into a registry when they're started on clozapine. The incidence is pretty low now, about 1%, but that is because we're more aware of the side effect and do a much better job with monitoring. When the drug was initially developed, there was about 12 fatalities that occurred within the first 5 years of using the drug in the United States. And so that's where some of the scare came from. The onset's usually within the first 8 weeks, and higher risk is with elderly patients, those that are female, those that are very malnourished or underweight, and then again, usually within 1 to 6 months of therapy, but typically within the first 8 weeks. The symptoms are pretty non-specific. It's things like sore throat, fever, and erythema. Of course, you can also check a WBC and ANC level. Agranulocytosis is defined as an absolute neutrophil count less than 500. This is a dose titration schedule, just an example that you can use, and using a slow dose titration helps prevent agranulocytosis. This is one that I prefer because I find that using doses higher than 100 milligrams in the morning tends to lead to too much sedation, but different drug resources will show you different titrations, and usually each facility has its own dosing procedure. What's really important here is recognizing that you must restart this titration if the therapy is interrupted for greater than or equal to 2 days. So if you have a patient that comes in to see you that typically takes clozapine, if they tell you that they quit taking it a week ago, you shouldn't just resume their home dose. You actually have to restart the entire dose titration schedule. There's a lot going on this slide. This is from the Clozaril package insert and kind of just goes through appropriate monitoring. What I really want to highlight here is that when you start a patient on clozapine, they have to get their WBC and ANC checked weekly for the first 6 months. Then from months 6 to 12, you'll check it every 2 weeks. And after 12 months of therapy, you have to check their WBC and ANC every 4 weeks. So even if they've been on the therapy for 10 years, you're still checking that blood count every 4 weeks. The rest of the chart kind of just shows you what to do based on if you get lower white blood cell counts or ANC numbers, and I don't need you to memorize any of that. Just want you to be familiar with how to initially monitor the WBC and ANC. We do have treatment options available if a patient does develop agranulocytosis. Of course, you want to discontinue clozapine, and most of the care is supportive. If necessary, you can start an antibiotic, especially if the patient's at risk for developing infection. And then there are things you can use to help increase the WBC and ANC. One of them is a granulocyte colony stimulating factor, so that would be something like filgrastim. Interestingly, lithium also can increase white blood cell counts, so sometimes because that is a mental health medication, you'll see it used for that. I won't go into the details. This is just to let you know that we do have treatment options available. Risperidone acts more like a first-generation antipsychotic at higher doses, and that's why I've already mentioned that we typically don't dose it more than 6 milligrams per day, because once we start getting above that dose, we'll see more of those extrapyramidal symptoms and hyperprolactinemia. And again, hyperprolactinemia is of clinical importance because it can lead to galactorrhea and gynecomastia, which patients do not like. Something interesting about this medication is that it appears pretty effective for handling behavioral problems like autism. It actually has an FDA-approved indication for pediatric patients for irritability associated with autism. They also use it for behavioral problems associated with mental retardation and dementia. Dementia is an off-label use because risperidone carries a black box warning in this patient population, and we'll talk about that a little bit more towards the end of the presentation. Paliperidone is the primary active metabolite of risperidone, so it's very similar. Their adverse reactions are very similar, and it's kind of just a me-too drug of risperidone. One nice thing is that it has minimal drug-drug interactions. However, it does require dose adjustments for renal impairment. Although you do not need to memorize this, I just want to highlight that it kind of has a unique formulation for releasing the drug, and this formulation helps reduce the peak-trough fluctuations that you'll sometimes see with oral dosage forms. And this is it uses an osmotic controlled release oral delivery system, and it uses osmotic pressure to deliver paliperidone at a controlled rate. So within the gastrointestinal tract, there's a water dispersible overcoat of the tablet that erodes quickly. Water is then absorbed through the semipermeable membrane at a controlled rate, which then controls the rate of drug delivery. The hydrophilic polymers of the core hydrate and swell, and this creates a gel containing paliperidone that is then pushed out through a hole in the tablet. Of the second-generation antipsychotics, olanzapine is closest in structure to clozapine than any of the other agents, so therefore, it's kind of hypothesized that olanzapine is also perhaps more effective than some of the other agents, but this isn't always panning out in clinical trials. And some of the side effects are also similar. In general, olanzapine has a better side effect profile, but doesn't tend to work as well as clozapine. You may see some extrapyramidal symptoms and hyperprolactinemia if this is used in very high doses. Like clozapine, smoking can decrease the levels, so you have to be careful if you have patients that either start or stop smoking. And then we've talked about this one having high cardiometabolic risks. With quetiapine, there's virtually no extrapyramidal symptoms or hyperprolactinemia, and quetiapine rapidly dissociates from D2 receptors and is actually one of the preferred antipsychotics for patients with Parkinson's disease. If a patient has Parkinson's disease and needs an antipsychotic, usually quetiapine and clozapine are the agents of choice. This agent can be very sedating, so we'll see it dosed at bedtime, and sometimes people will even use it if patients have kind of a comorbid insomnia. There was some initial concern about this medication causing cataracts, so sometimes you'll see eye testing recommendations for this medication. However, I have a beagle pictured because it turns out that it caused cataracts in beagles, and beagles are not humans, so we didn't actually see this developing in humans. So even though you may see things about eye testing, you really don't need to do that with human patients. This medication also appears to be pretty useful for anxiety and PTSD, so you may see it used in this patient population as well. Ziprasidone also has a low incidence of EPS and hyperprolactinemia. It can be activating at low doses, so when it's first started and given at around 20 to 40 milligrams twice daily, you can see some akathisia with that. There were some early concerns about QTc prolongation with this medication, and they now seem to be somewhat unjustified. I will say that of the second generation antipsychotics, ziprasidone tends to cause the most amount of QTc prolongation. But depending on the study done, this prolongation is usually anywhere from about 10 to 20 milliseconds, and there's no evidence to suggest that this causes torsades or sudden death. You should use it cautiously if the patient's taking other medications that prolong the QTc interval, but routine electrocardiograms are not generally recommended. QTc prolongation is more likely with something like thioridazine, but you'll also see it with clozapine and iloperidone. So ziprasidone has kind of gotten a bad rap for QTc prolongation, but it's not the only agent that you should be concerned about when you're thinking about QTc prolongation. Most of the antipsychotics have some increased risk, but the clinical significance of this kind of just depends on what other risk factors the patient has and the other medications they're taking. As mentioned, this medication should be taken with food, specifically fatty food, to help increase its bioavailability and absorption. Aripiprazole has a unique mechanism of action in that it's actually a dopamine partial agonist. And so under conditions of high dopamine levels, aripiprazole will act as a dopamine 2 antagonist, meaning that it will block dopamine. However, in low dopamine conditions, aripiprazole acts as a dopamine 2 agonist, meaning that it will help cause release of dopamine. So this medication can also be more activating, so it can cause things like akathisia when it's first started. But in general, it also is not really associated with as much movement disorders because of that partial agonist activity on dopamine. It can also lower prolactin because of this unique mechanism. And so sometimes when patients will have hyperprolactinemia on other agents and they really need to stay on that agent, you'll see providers add on low doses of aripiprazole to help with those prolactin levels. This one also has a pretty long half-life, meaning that it'll take a while for it to start working. So sometimes providers will become a little bit impatient with it, but you definitely want to, give it 2 to 4 weeks to really get a good effect with this medication. Acenapine has been associated with more orthostasis and sedation, so you want to be careful with how quickly you're titrating the dose or using this in our elderly patient population. We've talked about that this one is the only one with a true sublingual dosage form, so it's kind of a nice alternative for patients who are unable to swallow tablets. And one thing is that it is important to tell patients not to eat or drink for about 10 minutes after this has dissolved. Iloperidone also has a pretty significant risk for causing orthostatic hypotension, and it actually has a very specific dose titration schedule that is available in the package insert. You will titrate the dose slowly over a 1-week period, and if the patient misses 3 days or more of the medication, you do need to restart this titration. So this is generally a poor choice for acute treatment of schizophrenia due to that slow titration schedule. It's also a poor choice in non-compliant patients because of probably having to restart that titration schedule because of them not taking it. This one has QTC prolongation similar to ziprasidone, so just be careful with that as well. And as we've discussed, lurasidone also needs to be taken with food specifically greater than or equal to 350 calories. However, it does not need to be fatty food, so you can take it with a healthy meal. This also requires dose adjustment for severe renal impairment. This agent is theorized to have some cognitive and anxiolytic effects due to some unique aspects of its mechanism. It has some serotonin 1A partial agonist activity. However, clinically speaking, we haven't really seen this pan out yet. I just wanted you to be aware that that is one kind of aspect they've been marketing with this drug. We're going to conclude the presentation by talking about some special populations, and we'll begin with the elderly. We have to be careful because the elderly have increased sensitivity to side effects with these agents, specifically with the movement disorders and tardive dyskinesia. We'll also have to be careful with dosing due to impaired hepatic and renal metabolism. All antipsychotics have a black box warning for increased mortality in the elderly patients with dementia-related psychosis. And these deaths do appear to be cardiovascular or infectious in nature. And I highlight this because we can use antipsychotics in elderly patients with dementia, but we want to be very selective in who we're giving these medications to. In order to prevent any mortality associated with these medications, we want to determine underlying factors for their behavior. Are they, do they have an infection? Are they in pain? Is there something in their environment that's agitating them? And then that kind of goes into number 2 and 3 with eliminating precipitating factors and implementing non-pharmacologic treatment. We really want to make sure that the patient has appropriate lighting in their room, that their walkways and pathways are clear from clutter, and that their room is kept at an appropriate temperature. If necessary, you can initiate an antipsychotic, but you want to maintain it at the lowest effective dose and continually reassess need for an antipsychotic. So, just because it started doesn't mean that they have to be on it forever. Risperidone, olanzapine, and aripiprazole have data demonstrating efficacy in this patient population, so you'll often see those agents chosen first. With our pediatric patient population, we really have limited and sparse study data, so there's not a lot of evidence to support treatment decisions. However, schizophrenia is fairly rare in childhood. We usually don't see it develop until people are in their 20s, but you will see children that have schizophrenia. There are several agents that are approved for patients 13 to 17 years old, and risperidone is an agent that's used quite often due to it being effective for behavioral problems and aggression. It's important to recognize that children may be more sensitive to the extrapyramidal symptoms as well as the metabolic side effects, especially the weight gain, so that might be a good reason to choose one of those more metabolic neutral agents. The picture that I've shown here really has nothing to do with pediatrics, but I just found it interesting and wanted to talk about it briefly. These pictures were actually painted by a 20th century artist, and he painted pictures of these cats over a period of time in which he developed schizophrenia. So the pictures mark progressive stages in the illness and exemplify what it does to the patient's perspective. So you can see the picture starts out with a normal looking cat, and as time progresses, this cat becomes more and more scary looking from this patient's perspective. Finally, we're going to talk about pregnancy. Almost all of the agents are pregnancy category C. However, clozapine and lurasidone are category B. These agents can cause neonatal withdrawal symptoms and EPS, which can include things like agitation, increased or decreased muscle tone, tremor, sleepiness, and severe difficulty breathing. You might also see difficulty in feeding. So you really need to weigh the benefits and risks of treatment. I will say that most patients tend to be on these agents for life, and interrupting therapy for something like pregnancy is often more harmful than it is beneficial, especially if the patient ends up committing suicide. So for the most part, we'll generally maintain treatment before and during pregnancy for patients with chronic schizophrenia. However, we do want to make sure that we're keeping them just usually on one agent and at the lowest effective dose. In terms of breastfeeding, they say that infant risk cannot be ruled out, so you should weigh the benefits and risks before using these agents in breastfeeding. In summary, the antipsychotics other than clozapine are equally efficacious but differ in their side effect profiles. The first generation antipsychotics are more likely to cause things like extrapyramidal symptoms, neuroleptic malignant syndrome, and hyperprolactinemia, while the second generation antipsychotics are more likely to cause metabolic disturbances. Clozapine does demonstrate superior efficacy but is not used first line due to the multiple adverse effects that limit its use. And nurse practitioners can play a huge role in helping to monitor and manage the side effects associated with antipsychotics. Long-term maintenance treatment is necessary for most patients to prevent relapse, so therefore we often will not interrupt therapy for things like pregnancy. Thank you very much for your time.